Hi, I'm Steve Selig, founder of Fit Test, and in this third part of the series on chronic heart failure and exercise directed for exercise professionals, the topic of this video is heart failure with reduced ejection fraction, and I'm going to present a case study as well on this topic. What is heart failure? Here we have a healthy heart muscle with healthy blood supply, good contractile ability, the appropriate sort of pressures and outputs from this heart, appropriate cardiac output into the aorta. And here, heart failure, and the hallmark sign for heart failure is a less cardiac output, reduced cardiac output compared to what would be needed for that person at that time. And you can see here in this lovely cartoon the fact that the heart usually has to work harder to produce that cardiac output. And this is a really good way to think about heart failure. The hallmark sign, reduction in cardiac output. So the hallmark sign, as I just said, low cardiac output at rest, submaximal and maximal exercise. The hallmark symptoms, breathlessness on exertion, shortness of breath on exertion, and even at rest, and fatigue during exercise and even at rest sometimes. The functional classifications based on the New York Heart Association classification scheme. Class 1, symptoms at high intensity exercise. Class 2, symptoms at moderate intensity exercise. Class 3, symptoms at low intensity exercise. And class 4, symptoms at rest. Now for class 4, as I recommended in part 1 of this small series, chair-based exercise and low to at no more than moderate intensity interval training is good. And also often you have to use small muscle groups because large muscle groups are too exhausting for these clients. I also suggested that low, moderate, and even sometimes high intensity interval training is suitable for a lot of these other clients with heart failure, depending on what class they're in. You could certainly use HIIT for class 1. Class 2, I would generally stay at moderate and low intensity exercise for class 2 and class 3 because they're simply just too symptomatic at higher intensities of exercise. But I'm a big believer in interval training. Personally, for class 2, I would use MIT or moderate intensity interval training. I use that a lot quite successfully. Now, the topic of this video is on heart failure with reduced ejection fraction, otherwise known as systolic heart failure. The topic on part 2 of this series was heart failure with preserved ejection fraction or diastolic heart failure. But as I've been saying, there's a great lot of crossover between diastolic and systolic heart failure. This is not an either-or situation. Most clients will have features of both. So just to continue on with now to have more of a pictorial representation of heart failure. In a normal heart, we have the chamber size that I've outlined with the black line. Normal looking ventricular wall with a sort of normal thickness. The pressures generated in the left ventricle are normal. And so it produces normal stroke volume and normal cardiac output into the aortic arch. So this is just a normal satisfactory cardiac output for this heart that's apparently healthy. Now, if we go to heart failure with reduced ejection fraction, which is the topic of this video, otherwise known as systolic heart failure, an example of this would be a large dilated ventricle. You can see the black outline now is much larger, and the heart has even some wall thinning, and there's a weakening of the heart muscle so that it can't contract. In other words, it can't produce that systolic function to the same extent as the normal heart. So large dilated ventricle. If you go to my video on YouTube, my YouTube channel on preload or the Frank Starling law of the heart, I've given a lot more information about this sort of heart and what effect that has on stroke volume. So please go and look at that video because it will give you that information in much more detail than I'm going to give here. So just coming back to this sort of heart has lesser ability to contract, and that produces lower stroke volume and in turn lower cardiac output. This is not the only form of systolic heart failure, however. People who survive a myocardial infarction haven't as yet got a dilated cardiomyopathy like this, but they have weakened heart wall because there'd be a wall of a region of the ventricular wall that's no longer contracting. So a different shape, it'll look more like this, but with far less contractility. And again, that will produce less stroke volume and less cardiac output. So the take-home message here is this is not the only heart form that it can be described as systolic heart failure. There are many other forms, but it gets the message across pretty well. Now, in part 2 video, I talked about the topic of that video was heart failure with preserved ejection fraction or diastolic heart failure. And I described that as a small, thick, stiff ventricle, thicker wall, smaller chamber size. And the biggest problem here is impaired filling of that left ventricle, where the filling pressures go up quite a lot inside the left ventricle and in the left atrium. And as a result of that, there's a problem with filling of the left ventricle, which then transmits into a reduced stroke volume and reduced cardiac output. So we have, for both of these forms of heart failure, reduced cardiac output, which is the unifying clinical feature, but for very different mechanisms. Now we come to the HFrEF literature, a little bit of the literature now. This is by Peter Brubaker and colleagues in the Journal of the American Geriatric Society in 2009. And what they looked at were some very sick clients. The participants in this study were really very, very sick with that VO2 down at 14. And in part 1 of this series, I've said quite a lot about VO2s at the 14 mark. And these are people who are, functionally, they're probably at least class 3. They might be class 3B. These are quite sick clients. And I guess that explains a lot about why in this exercise training study, they struggle to report changes in VO2 peak. I see a lot of clients who have much higher starting VO2 peaks, and we can improve on them. So although these results don't show any improvements, significant improvements in VO2 peak or in 6-minute walk distance, pre and post training, what they do is what I find when I'm dealing with people who have a little in better clinical condition than this cohort here, I certainly can get improvements in fitness and function and VO2 peak and quality of life and so on. So they didn't get any changes in VO2 peak or ventilatory anaerobic threshold or 6-minute walk distance or quality of life and left ventricular volumes, ejection fraction or diastolic function. So I suppose a bit discouraging, but the thing is we need to keep trying, because I'm sure if we do nothing else, we're very likely to improve the quality of life and perhaps improve people's symptoms after exercise training. So this is not to say we don't recommend exercise for people with HFrEF. We certainly do. This is another big study in JAMA by O'Connor and colleagues, a multi-centre randomised controlled trial of 2,331 medically stable patients, outpatients with HFrEF. And again, we don't see much change with peak oxygen consumption after training. We see an improvement of 0.6 versus 0.2 for the controls, and then baseline of 12 months we saw 0.7 against 0.1 for the controls. So there's a small tendency to improve VO2 peak, but really quite a weak or small effect size. Now again, a small effect size on the cardiovascular mortality or heart failure hospitalisation rates were a little bit improved, significantly, but only a small improvement for those who did the exercise training. And for cardiovascular mortality or cardiovascular hospitalisation, again, a small improvement, statistically significant, but the effect size is quite small. So these studies are showing that exercise training is not doing a lot physically for these clients, But as I said, I take clients who start off with in much better condition than probably these participants, and I get very good results pre and post. And I'll show you one of my clients in a minute in the next couple of slides. So just to summarise the literature that I reviewed for HFrEF is that and I haven't shown all of this in the previous slides just to keep it brief, cardiac rehab improves lives and saves lives. We know that across cardiac rehab in general. Exercise is a critically important element of cardiac rehab. Exercise improves the lives and VO2 peak of clients with HFpEF more than for clients with HFrEF, but both benefit. That's not a reason not to apply exercise for HFrEF. Benefits include improvements in symptoms and increased energy and improvement in quality of life. Peripheral mechanisms mostly are responsible for the exercise benefits for people living with heart failure. And by that I mean we don't see centrally great improvements in either systolic or diastolic function, but peripherally the muscles seem to be able to take up and use more oxygen after exercise training. And so the improvements are attributed to peripheral mechanisms rather than central mechanisms. So now to come to my case of someone in chronic heart failure with 30-year plus history of coronary artery disease and multiple myocardial infarctions way back in the 1980s, going through to the early 90s, multiple coronary artery bypass graft surgeries in 1993, and incidentally, he's still alive in 2020, so we're talking 27 years after diagnosis of heart failure. I want to emphasise this is a person who has exercised all his life, but he was unlucky to get major cholesterol problems. They would have been familial, that caused a lot of problems both in myocardial infarctions leading to heart failure. The drugs he was taking for his heart failure included the angiotensin blocker, the beta blocker, atenolol, the mineralocorticoid receptor antagonist, spironolactone, and cardaprem, which is an aspirin-like drug for anti-coag. And then he was also taking simvastatin for lipids, large dose. He was unlucky to be diagnosed with celiac disease, or lucky to be diagnosed, but unlucky to have it, with a very low hemoglobin, which was really messing around with his ability to cope with heart failure. And after this was discovered, the celiac disease was treated with dietary approaches, and his hemoglobin was normalised at 13. Way back in 2007, he was first diagnosed with aortic stenosis with a smallish left ventricular aorta pressure gradient of 15 millimeters of mercury. And I've produced YouTube videos on aortic stenosis, which you can see on my YouTube channel. In 2012, he had an atrial flutter, which was treated with amiodarone and the beta blocker atenolol. In 2013, it was thought wise to pace him, and he's now got biventricular pacing with no atrial pacing because his atria are not susceptible. There's still a lot of atrial fibrillation, atrial flutter, so not suitable for atrial pacing, but he has biventricular pacing for cardiac resync therapy to try and get the ventricles working optimally. Unfortunately, in 2018, his aortic stenosis had progressed to where his left ventricular aortic pressure gradient, it wasn't actually 26, it was 46. That's a mistake. So 46 millimeters of mercury. He went to surgery, and he had transcatheter aortic valve implantation. In North America, that's called replacement, but in Australia, it's called implantation, or TAVI. And that's he would have been too sick to have open chest, open heart surgery for valve replacement, but the TAVI has probably gone a long way to saving and extending his life and quality of life. Now, to come to his fitness, this is what I was saying before. This man with all of this morbidity, all of this cardiovascular morbidity, is still able, with a lifetime of exercise, to get to a VO2 peak of 24, which is remarkable, really. And notice his heart rate peak of 83, which is only 53% of his predicted. And that's the atenolol and the other drugs he's got on board, and also his atrial dysfunction, and he's on biventricular pacing. So that heart rate's very low, and it's probably been programmed to stay that low. I'm not going to go into the reasons why it is here. His peak power on the cycle ergometer was 102 watts, and speed peak was 25 kilometres an hour. Remarkable numbers for a 76-year-old male with all of this cardiovascular morbidity. So that's where he is. He's actually average fitness despite all the morbidity. Wonderful effort. And I am yet to post-test him, but I'm sure he'll be able to maintain. He's maintaining this sort of fitness over a long period of time. So thank you for watching this video on HFrEF, heart failure with reduced ejection fraction. And you can contact me at info@myfittest.com.au. If you want any cardiovascular topics covered, please email me, and have a great day. Bye for now.